Just check. Not yet arrived. Oh, there it is.
Good, good. Thank you.
Okay, Kamal, I'll share it with you and answer.
Okay.
Okay.
Okay, so you'll share from your side.
Okay.
In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, colleagues, and welcome to our weekly webinar presentations. And as our tagline says, welcome to Clinics where health and care meet. And it's one of those ways that we ensure that we provide the care that is expected of us in the communities. And also we've got top-class specialists and healthcare workers working at this at our facilities. And we also do this by ensuring that we present you with up-to-date information on clinical care and also provided by specialists in their own fields who are experienced clinicians and academics. And so this is one of those evenings that we continue with these presentations. Please note that these webinars are CPD accredited, and for you to get your CPD points, you need to make sure that when you log in, you provide us with your full details, name, surname, and proper email address or correct email address, and your contact details, mobile contact details, and the correct registration number details, MP, or whatever profession that you are registered with, either with the HPCSA, the Nursing Council, the Pharmacy Council, or the Allied Health Professions Council. And so this evening, we are continuing with our series on important clinical practices that we want to inculcate in our ways of doing and practicing medicine. And so we have Professor Yasmin Adam, who's coming back for the second time. They've been with us a few weeks back, and she'll be talking to us about pre-eclampsia and adherence to a protocol. Professor Yasmin Adam is the academic head of the University of the Witwatersrand and also the clinical head of the Department of Obstetrics and Gynecology at President Baragwanath Academic Hospital. The publications are mainly in the field of prevention in cervical cancer. She has supervised more than 40 MECs and is an internal and an external undergraduate, postgraduate examiner, and actively involved in undergraduate and postgraduate teaching at the University of the Witwatersrand. She's also strongly committed and involved in clinical audits, risk management, research and development, information management and clinical effectiveness. She has developed and contributed to guidelines and has been actively involved in community interaction, giving talks at health awareness events as an invited speaker. Hence, this evening, we want to talk about pre-eclampsia and adherence to a protocol. So welcome, Professor Yasmin Adam, and we're looking forward to another exciting evening as you share your expertise and clinical knowledge with us. Thank you.
Doc, we seem to have lost Prof. Let's just try getting back on.
Oh, sorry about that, colleagues. Professor Yasmin Adam was logged in. It looks like she's got a challenge with connectivity where she is, but we'll give it a few more minutes and she'll be joining us again. Let me just check it out. Okay, thanks, colleagues. We have made contact with Professor Adam. She'll be joining us quite soon. She's had some difficulties with the connectivity, but as soon as she is back online, we'll continue with our presentations. These things happen with load shedding and power failures that we're experiencing in our areas. From time to time, it does happen. But we trust that you'll give us a few more minutes. I think she has logged in.
Yeah, thanks so much, Dr.
Thank you very much. Thank you. Welcome. We've done the introductions and quite a number of people waiting to hear from you.
Okay.
Thank you. Kamo will be able to help with the slide presentation.
Okay.
Yeah.
Thank you so much. Thank you very much, Dr. Bila, and thank you to Clinics for inviting me to do this talk. I think we, as obstetricians and also as primary healthcare workers, we see a lot of hypertension and we see a lot of preeclampsia. So what I thought I would do is I would actually look at the protocols and look at the protocols with different obstetric societies and look at where we are and how easy it is to adhere to a protocol. So the next slide, please. So I'm going to talk about the importance of hypertensive disease in pregnancy, and then what are the avoidable risk factors in maternal deaths from our Saving Mothers report. So that's about the same in the last three triennium. Long-term risks for the mother and the baby, so a long-term morbidity actually, and then how do we screen in order to prevent, and then I'll talk a little bit about prevention. The definitions are very similar, but I just want to go through the different definitions of preeclampsia and then about when should we be delivering, and very little then, and then going on to the postpartum period. The next slide, please. So this is from the Saving Mothers report, and we've made great inroads into reducing the non-pregnancy related infections. And this was because of everybody working together. So introducing antiretrovirals would not have made the difference until we changed all kinds of logistics in order to get the antiretrovirals to all the people who needed it. But that was a huge reduction. Then if we look at hemorrhage, it's slightly lower than it was in the previous triennium, but hypertensive disease of pregnancy is almost exactly the same over the triennium. So it makes up about 18 to 20% of all the maternal deaths. So hypertensive disease of pregnancy, it's all the hypertensive diseases, not just preeclampsia and eclampsia. But preeclampsia and eclampsia is associated with much higher morbidity and mortality than other hypertensive diseases of pregnancy. So it is important. The next slide, please. So then if we look at what causes hypertensive disease, what are the causes of death in hypertensive diseases, it's cerebral hemorrhage and pulmonary edema. And cerebral hemorrhage is 3 times higher in patients with preeclampsia than in patients just with hypertensive disease of pregnancy. Also from the Saving Mothers report, the avoidable factors for hypertensive diseases. The avoidable factors for hypertensive diseases were thought to make up 70%. So if we look at the avoidable factors, we should be able to reduce the death from hypertensive diseases because of the avoidable factors. And then the avoidable factors that they looked at was assessment. So the assessment of hypertensive disease of pregnancy and also preeclampsia, making the correct diagnosis. Delay in referral was also a big problem, and patients that weren't referred at all, making the wrong diagnosis, confusing it with other aspects, or not knowing that there's severe hypertension, so not looking for organ dysfunction in a patient with hypertension, and not following the protocol was, I think, very important. Poor monitoring, so not monitoring adequately and not writing our notes adequately to make sure that the monitoring is as expected. And then when there is monitoring, then not responding to that. So then if we look at the long-term risks, so the morbidity in patients who have got preeclampsia, the mothers' cardiovascular diseases is ongoing. So patients who have got preeclampsia have got a 50% chance of being hypertensive during their lifetime. So they need ongoing surveillance for hypertension. Obesity is also higher in patients who have had preeclampsia, and of course kidney disease, which may be due to acute kidney dysfunction, which happens with preeclampsia, and then that is then ongoing. So we need to look for this afterwards. Children born to mothers with preeclampsia have got an increased risk of abnormal psychomotor development. There's an increase in insulin resistance, also in diabetes mellitus, and also cardiovascular disease in the children. So the children born to mothers who have got preeclampsia will themselves have an increased risk of preeclampsia, but will themselves also have the risks of insulin resistance, diabetes, and cardiovascular diseases. The next slide, please. So avoidable factors in terms of protocols. So there's some publications which look at the presence or the use of protocols. And the one that they use, and this was from New York State in the US, where adherence to a hypertensive disease of pregnancy protocol is associated with reduced maternal morbidity and mortality. So what they have with a lot of their management of emergency conditions, they have a bundle. And so similar to what we have in terms of with ESMO, where we say that this is what you need to do when you diagnose an emergency, and they have these bundles. And they have a bundle for the management of severe hypertension. So once you've diagnosed it, what time, how long must you repeat the blood pressure and to call for help? And some of it we're going to go through in terms of when I talk about the severe hypertension. In terms of safety bundles, they look at readiness for the urgent condition, recognition and prevention, and then response and reporting, and then systems learning. So going all the way back to say where there was a problem when you do have a morbidity and certainly a mortality. Then the second study, which also looks at a protocol and really is the medical, it's the early warning tool. So it's for particularly in pregnancy, and that is linked to a clinical pathway. And with this early warning tool, they addressed 4 of the most common areas of maternal morbidity: that's sepsis, cardiopulmonary dysfunction, pre-eclampsia, hypertension. And that is, again, it is also in the United States. And what they did was they looked at a before and after. And they also had some hospitals where they didn't introduce the early warning tool. And they found, when they compared it, that when they looked at the after introducing the early warning tool, they found that there was a reduction in maternal morbidity. Next slide, please. So we have some medication that we can use in terms of preventing preeclampsia. And in the South African hypertensive guidelines, we look at using high risk factors for determining whether a patient should get aspirin or not. And the high risk factors that we look at is prior preeclampsia, chronic hypertension, multiple pregnancy, pre-gestational diabetes, a BMI of more than 35, antiphospholipid syndrome or SLE, and also women who have undergone assisted reproduction. So those and many societies look at screening just with history. The FIGO screening is where they use maternal risk factors. They use the maternal mean arterial pressure at booking. They measure the placental growth factor in the first trimester and the uterine artery pulsatility index, so around about 12-13 weeks of gestation. And this is done as a one-step procedure. And when using these parameters, they would determine a risk. And if the risk of preeclampsia was 1 in 100, so 1%, they would then administer 150 milligrams of aspirin daily. So this is information this was taken from the aspirin trial. So the aspirin trial, or the ASPRE trial, was published in 2017, and they screened women in the first trimester. They used maternal risk factors, mean arterial pressure, placental growth factor, and PAP-A, and uterine artery pulsatility index. And again, if the risk was more than 1 in 100, they would give aspirin 150 milligrams. In that trial, they showed a reduction in early preeclampsia of about 56%. which is really excellent. But with that study, what they did was they had all patients coming in the first trimester, and they put all of these screening parameters that they used together. So although it's a randomized control trial, it really is very specific for women who were positive by this method. And I'm going to show you what the doses of aspirin are in a bit. But then you would think that we don't have the resources, and we certainly would need training if we were going to measure uterine artery pulsatility indexes, and we would need early ultrasounds in all the patients if we were going to use that screening tool. The American College suggests that the placental growth factor and the uterine artery Dopplers have a low positive predictive value. And as far as they're concerned, this should remain investigational. They also work out the cost of doing just the ultrasounds in early pregnancy, and that would work out to about $4 million per year. So not just in South Africa are we talking about the resources in terms of people and in terms of logistics, but in a country that where you think that they would have the resources, they're also not doing that kind of screening. So then if you look at, so how much of aspirin should we give? So it's clear that we must give aspirin to patients who screen positive, with whatever screening method you use. But look at I think that the closest that we get to all the societies doing similar things is an agreement on starting as early as possible. So in South Africa, 12 to 14 weeks, and then in the States, so the ACOG guideline, where they suggest starting before 12 weeks. But they say that you can start up to 28 weeks. And they are the only society that allows starting up to 28 weeks. And then the WHO, which says start before 20 weeks. And then Queensland, which is one of the Australian societies, look at, they say start as early as possible. And I haven't put it onto the slide, but all of them say start at least between 12 weeks and up to 20 weeks. Then the dose. In South Africa, the dose is wide. I mean, it's 75 to 162. So we really need some clarity from the societies in terms of what or how much aspirin to give. So we think that the amount that you should be giving is somewhere in between. So we think it's higher than 81, so clearly higher than 75, but probably closer to 100. And then the dose with WHO still sits at 75, and at Queensland they look at 100 milligrams. And then the ACOG, which was a 2019 publication, they're looking at 81 milligrams, so much lower than the 150 suggested by the ASPRI study. South Africa, we have giving calcium, so 500 milligrams with a 2-hour gap between the iron and calcium, so that they don't interfere with absorption, and that we say starts at any gestation. The other societies, including the WHO, say that to start calcium in those areas where there's a reduced calcium in the diet. They then go on to say that in terms of prevention, that they should not be looking at a no strict bed rest, and vitamin D and vitamin E haven't been shown to reduce preeclampsia, and they do not suggest that there should be salt reduction in patients where you think that you need to prevent preeclampsia. So the next slide, please. So then the concept of prehypertension is important, and it is discussed. It was discussed even before the South African guidelines, and it's also discussed by the International Study Society for the Study of Hypertensive Disease in Pregnancy. And this is a blood pressure of 135 to 139, that's the systolic, and a diastolic of 85 to 89. Apologies for that. And then the blood pressure should be repeated at that same visit within 30 minutes or to 2 hours. And if it's still borderline, then the patient should return within 3 to 7 days. Obviously, if it's high, the patient then you would have to repeat it to know whether the patient is hypertensive or not. And they say that after 7 days, if the blood pressure is normal, then the woman can be followed up as a low-risk pregnancy. The ACOG, though, also suggests that you look at the concept of prehypertension or hypertension, they grade it. And then they suggest that the significance of these parameters is uncertain, but it does need to continue. Next slide, please. So then the diagnosis of hypertension. Hypertension in pregnancy in South Africa is defined as a blood pressure of 140/90, and this is measured on 2 occasions at least 15 minutes apart, and that must be at the same visit. ACOG similarly, but they look at 4 hours apart. The Australian societies use this 30-15 rule, which is an increase in systolic blood pressure of 30 and an increase in the diastolic blood pressure of 15. And that is because, and that is compared to the baseline blood pressure before that. So overall, there's agreement in terms of the diagnosis of hypertension. And it's extremely important that we all follow this and make the diagnosis. Next slide, please. So then severe hypertension. So severe hypertension is a systolic blood pressure of 160 millimeters of mercury or more, and a diastolic blood pressure of 110 millimeters of mercury or more. And this means that you need urgent lowering of the blood pressure levels in pregnancy. This is the same for 12 out of 13 ONG societies, with the only other one saying that looking at the systolic blood pressure of 170. The diagnosis of preeclampsia then is hypertension accompanied by either proteinuria, but you don't need proteinuria, or evidence of organ dysfunction. And this is after the 20th week of pregnancy. Prior to the 20th week of pregnancy, hypertension would be chronic hypertension. And so this also is the same for most societies. And in fact, the difference is just in the way that they define thrombocytopenia, with most societies defining it as less than 100. And in South Africa, we just take a raise in transaminases. So if your AST and ALT are greater than 40, we would diagnose organ dysfunction, and that would be liver dysfunction. And a creatinine greater than 90 would mean that there is renal dysfunction. And that is then the diagnosis, and that's the same. So then when do we start antihypertensives? In South Africa, we have to the trigger and the target is almost the same. So we start antihypertensives at 140/90, and the South African recommendation is that we then give 750 milligrams of methyl-dopa 3 times a day, and that the target must be less than 140/90. The American College says you only need to start antihypertensives at a blood pressure of 160/110. So that is based on a study, and that is also, the last was 2019. And that is based on a study where they compared tight control of blood pressure versus loose control. So tight control of blood pressure was a systolic blood pressure of less than 135/85, and loose control was anything less than 160/100. And then they then compared, the onset of preeclampsia, and there was no difference in the onset of preeclampsia in the two groups. But what they did find is that in the group where there was loose control, that there were more peaks of a high blood pressure. So if you're going to use a loose target, like saying you're only going to start antihypertensives if the blood pressure is less than 160/110, then you do need to see patients a lot more frequently. The International Society for the Study of Hypertensive Disease in Pregnancy also starts at 140/90, and they look at this concept of the white coat hypertension, and so they would also look at blood pressure at home. And the target is a systolic of between 110 to 140/85. So, I think apart from those societies that accept that that loose control and tight control didn't increase the preeclamptics, I don't think that in South Africa we can use that at all. And partly because it would not be easy for us to see patients that frequently, and that I think is a problem. So hospitalization. So once a patient is diagnosed with preeclampsia, we admit those patients, and we admit them until they are delivered. The American College, they only look at hospitalizing patients with severe features, but they can then see patients much more frequently. So 2 or 3 times a week if they're preeclamptic. We admit patients with severe preeclampsia into our high care until we've got control of their blood pressure. And if we decide that we're not going to deliver, then only will we send them down to a lying-in ward. But we keep them until they've delivered. The Canadian guidelines mix hospitalization with day visits. So they also talk about hospitalizing patients with preeclampsia, but they have this concept of day hospitalization. So patients will be allowed to go home for the night. All societies agree that women with severe hypertension or severe preeclampsia should be admitted. Then when to deliver, because with delivery, if you deliver too early, then you have the problem with prematurity and all its problems. If you wait, then you increase your maternal complications. So in South Africa, we say that there should be strong consideration be given to all women who present with preeclampsia at 34 weeks of gestation. If you go above 34 weeks of gestation, you need to discuss. There must then be shared decision-making with the mother to understand the risks for her versus the risks for the baby. So there's a case that happened in the last year in a patient who had preeclampsia, and the decision was to deliver her at about 34 weeks. She was in the hospital, and she was 33 weeks and some days, and the decision was to wait until 34 weeks because of the baby. And this mother had an abruption and lost the baby. So it really is very difficult, and in obstetrics we can't predict an abruption, and so there really has to be shared decision making. The American College suggests that for mild to moderate patients with preeclampsia, you can go to 37 weeks, but with severe preeclampsia, you should be delivering at 34 weeks. So ultimately, the treatment for preeclampsia is delivery. And so with the WHO, the recommendation is that you should deliver for women with severe preeclampsia when the fetus is not viable, or if the fetus is unlikely to be viable in another 1 to 2 weeks. So if you've got a patient, if you've got a baby that's 650, that's very small. And you can expect this baby to grow by about 8 to 10%. So that means within a week, you'll get this baby you'll have to add 6 grams if you add 10%. So you would, if it's 650, then in a week's time, you would get to 710. But you really need to be watching the mother carefully. Expectant management, they say, is of severe preeclampsia can be offered up to 36 weeks and 6 days in the absence of uncontrolled hypertension and end organ damage or fetal distress. So that's a small group of women, and it's women who have got hypertension that's controlled, and so then it would be only proteinuria, because everything else would mean that there's organ dysfunction. So Phoenix, the Phoenix study, which was a study where they randomized almost 1,000 patients to either deliver at 34 weeks or to have expectant management. And this was a study that was done in high-income countries, and these were patients that were admitted. The primary maternal outcome was lower in the planned delivery. So the primary maternal outcome was it was maternal death, it was morbidities in the mother, it was organ dysfunction, and that was less by 14%, and which is as expected, because this is a condition that is worse for the mother. The primary perinatal outcomes was higher in the planned delivery group, with 26% more babies being admitted to the neonatal unit, spending more time in the neonatal unit. But there was no difference in babies, in respiratory distress in babies. There was no difference in neonatal deaths in this group. So it was really just the admission. And in their discussion, they talked about the fact that these babies were almost admitted because it was the plan is that you would admit babies that were born earlier. So even if you look at the difference in the number of days, that's a median number of different days of days. So in the planned delivery group, the median number of days, gestational age days, was 252. In the expectant group, it was 257. So the median, you weren't gaining very much. So there was a 5-day difference in what you would gain in the two groups. If you are going to keep a mother and you're not going to deliver after 34 weeks, then there must be shared decision making. I think you need to be able to say to the mother, the chances of this happening is 1%, or the chances of your baby being admitted is 26%. And then looking at it, and then also discussing what the reasons are. Next, please. Okay. Then severe hypertension, persistent severe hypertension that can occur antepartum, intrapartum, or postpartum. And it's diagnosed by looking at two values of equal and more than 160/110, and taken 15 to 60 minutes apart. The repeat blood pressures do not have to be consecutive. And the treatments that we have nifedipine, labetalol, and hydralazine. We don't have hydralazine in Gauteng, but they have hydralazine in the Western Cape, and it was used, we used to have it when I was the registrar. I put sodium nitroprusside and nitrites in because those are agents for the management of urgent or emergency blood pressures in patients outside of pregnancy. In pregnancy, sodium nitroprusside is a concern because of the cyanide and the thiocyanide. Nitrites as well. So if we were going to use that, it would have to be postpartum. Sodium nitroprusside we would only give in a high care setting, and certainly the nitrites we would get for the physicians to be involved with the management of the patient. So we admit the patient, and I'm going to just say preload, but I'm going to talk about that in a little bit. Then we use nifedipine, and we give 10 milligrams every 30 minutes for 3 doses if the blood pressure is still greater than 160/110. And our target is to get the systolic less than 160 and the diastolic as close to 100 as possible. If we still don't have control, we'll then use labetalol. That's 20 milligrams per hour, and that we increase every 30 minutes. The maximum dose for labetalol for us is about 300 milligrams per 24 hours. The maximum dose for nifedipine that I've seen is 120 milligrams, and that I think is what we would look at. And but I also saw in one of the other guidelines that they had the maximum dose for nifedipine was 180 milligrams. And then this is an American guideline on the right-hand side, and they admit, and they would give nifedipine 10 milligrams initially, and then so just once, and then if after 20 minutes, because they measure every 20 minutes, if the blood pressure is not down, they would increase the dose to 20 milligrams of nifedipine and then give another 20 milligrams, and that's 2 times doses. And if that doesn't work, they go on to labetalol. And the labetalol is different in the way that we use it. In the UK, they don't use nifedipine, they use labetalol. So the reasons that we look at nifedipine is that it's easy to give nifedipine. The other problem is that previously we used to preload the patients when they had a severe hypertension with 100 milliliters to 300 milliliters. But because of the risk of pulmonary edema, that we are no longer doing that. And that is on our protocol, and that is also in the protocol for the South African guidelines. And I see that it's also being removed in many of the other society guidelines. But the reason also for the preloading is because you don't want to drop the blood pressure precipitously. And that's why I've put out the preload. Apologies, I'm sitting in the dark. That wasn't even because of load shedding. So the fluid management, this is what is said in the South African guideline, is that IV fluid loading should be avoided and a policy of normal fluid balance be employed. In addition, a key point in the guideline is to avoid fluid loading because of the dangers of pulmonary edema. So the fluid restriction for a patient. When we put up a drip, it's really just to have access. And you are giving patients quite a lot of fluids anyway. Postpartum is very important. We must always remember that of our maternal deaths, 2/3 of them happen in the postpartum period. The recommendation is that we don't stop the antihypertensives at the time of delivery. You only gradually reduce them in about 48 hours. You can use diuretics with angiotensin-converting enzymes if you are going to change your antihypertensives. And then the patient, what is also important, and we forget this, is the psychological and the family support. The patients should not be discharged before 24 hours if they have preeclampsia, and if they've got severe preeclampsia or severe hypertension, they should not be discharged before 3 days. If you are discharging patients with hypertensive disease in pregnancy, they need to be seen within 3 days, and then depending on the blood pressure, they need to be seen again a week later. And again, depending on the blood pressure, if you've got control, you might need to see them more frequently until the 6-week visit. And then if they've got proteinuria, they still need to be seen again at the 3-month visit. And if they still have proteinuria at the 3-month visit, they need to be referred to a physician. I think that was my last slide. In conclusion, protocols are useful because all health workers have the same management plan. The protocol has to be suited to the population you serve. So there are reasons that we started off so early saying that we don't want fluid to be, we don't want to preload patients. There must be shared decision making, particularly when the triggers and the targets for therapy are wide, or when they are different in different societies, or when there's some controversy. All ONG societies agree on screening, but different screening, that prevention is important, the definitions of hypertension and preeclampsia, and urgent treatment of severe hypertension is the same in all of them. We use different drugs. The differences relate to triggers and targets, so in blood pressure, and when do we start treatment in patients without severe hypertension. And of course, some societies are more specific in defining exactly what they talk about when they talk about organ dysfunction. Thank you very much.
Thank you very much, Professor Adam, for this insightful presentation on a very common ailment or disease in pregnancy. And I've seen quite a number of colleagues who are making some comments and in agreement, and also the number of those who have logged in tonight shows that there's a huge interest in this topic. In your conclusion, you say that the protocols should be determined by the societies that we live in. Would you describe the South African society as one society compared to the Americans, the Australians, or you were saying even within South Africa, there could be reasons for having different protocols?
Yes. So, Dr. Bila, thank you for the question. Absolutely. I think that there are reasons that we use 10 milligrams of Adalat, and you saw in the American guideline, they go from 10 to 20. And part of it is because we're saying that we don't want to preload, and also we don't want to drop the blood pressure. So I think those are very important. So when they drew up the guideline, one of the important other guidelines and that they looked at was the international study, the International Society for the Study of Hypertensive Disease. And generally, we really look at WHO, and we look at FIGO for the way forward. But in this instance, we're taking it from the International Society for the Study of Hypertensive Disease. So you do need to look at the protocol and the guidelines that are written specifically for South Africans.
Thank you very much for that. And one of the first question is about the use of aspirin. And Dr. Shimanga says the Berkay aspirin 100 milligram is available straight in South Africa. Is that not sufficient? When you've given a wide range, there's a scope for the dosage that we should be using.
So I think that is fine. And just, I'm talking to many of the fetal medicine people in Gauteng, we are thinking that it's 100 milligrams is probably a reasonable way to go.
Okay. And the follow-up question from Dr. Chimang again is that the shared decision-making is very important, and says that you make absolutely clear that the patient understands and document, and this is documented fully. Discuss and document it.
Yes, no, absolutely. I think we do need to document. And the difficulty with shared decision making is that your discussion is individualized for that patient. So it is important to write down, to document what it is that you've said.
Okay, no, thanks. I think Dr. Mahoma just re-emphasized the fact that we should use science and the best evidence that's available. And you've just indicated that the different studies, but we're looking at the South African community and use the best protocols that are suited for our conditions. The next question is from Dr. Desai. How significant is the FLT-PIHF ratio in determining adverse outcomes? Is it used, if used, is it sensitive and specific? Maybe just to go through those, the markers, just indicate, maybe, I don't think you covered them.
So Dr. Desai, yeah, I think, so the group that used the SFLT and the placental growth factor ratio was mainly from Oxford. And in the main, it really still is an experimental. It's, you know, it's difficult to look at it to use clinically. And in the way that they had used it in one of their studies, which I think was published, was to look at the ratio in terms of predicting preeclampsia. But already they were looking at a group where they were looking at late preeclampsia. So certainly I think that we will see that it will start to be important, but at the moment, in terms of clinical management, I don't think it has a place for us yet.
Okay, thanks, Dr. Desai. Well, Dr. Maharaj wants some advice. A patient with spontaneous rupture of membranes at 2 weeks, the BP is controlled, no fetal distress, absence of contractions. How would you manage this patient?
So, this patient has just got hypertension, and this patient doesn't have preeclampsia. So, with rupture of membranes, so I would separate both issues. I would look at the preeclampsia separately, and I would look at the hypertension separately. So, I mean, the rupture of membranes separately from the hypertension. So, for rupture of membranes, you want to watch the patient, and for infection, and certainly if there is infection, then you're going to want to deliver. If the patient has stopped draining LICOR and has stopped draining for 48 hours, and on CTG, the baby is fine, there's clinically no features of infection, and on ultrasound, there's an accumulation of fluid, then you would just wait with that patient. As far as the hypertension is concerned, you need to look for organ dysfunction. So you need to know whether there's proteinuria, and then you need to do an AST/ALT, and you need to do a UNE, and you need to do platelets. So I think you need to just separate both those conditions. And certainly, the patient should get steroids and magnesium sulfate for neuroprotection. But I would separate them. I would say, even though you've got both conditions together, I would separate them and treat them differently.
Okay. Yeah, Dr. Desai wants to know more about magnesium sulfate. You just mentioned it now. A place for magnesium sulfate in preeclampsia, or?
So, we would give magnesium sulfate to prevent neurological complications. So, in patients with severe hypertension, with severe preeclampsia, you would give magnesium sulfate. and you give the magnesium sulfate for 24 hours after a seizure, or 24 hours for after a delivery, if you are going to be doing it for at the round about the time of delivery. And then the other time is to give the magnesium sulfate for neuroprotection. So so our protocol for our obstetric management is to give magnesium sulfate for prematurity up to 32 weeks. And we use the same protocol. We use either the Pritchard regimen, or we use the where we load with the IV and we maintain with an IV dose of magnesium sulfate.
Okay. It's good to see that we also physicians amongst us, because such patients are treated jointly by physicians and obstetricians at times. Because now that Dr. Kayinza wants to know, talk about postpartum preeclampsia. The period in which it occurs in its management, what is the role of long-acting Adalat? That is Adalat XL as opposed to methyl dopa or Aldomet and its attendant complications.
So if you've got a patient who is on Aldomet, and if you need to change if her blood pressure is controlled, then you may want to reduce her antihypertensives. But if you're going to reduce the antihypertensives, you need to do it with her in the hospital. And then if you stop one and change another, if you've got a patient on one antihypertensive and you stop it and she has an increase, then I think that you're stopping a drug where you've got a therapeutic level, and then you're starting another one. So you would need to start the other one at the same time, but you would, to stop it and start it, just doesn't make good sense. And the South African guideline is quiet about it. They just talk about reducing it. They don't talk about stopping it completely. So then, if you are going to stop it, then the long-acting calcium channel blockers are completely fine, and we would use amlodipine, or we would use Adalat, and then we may also use enalapril in the patient who is postpartum. But I personally don't stop the Aldomet in a patient who is postpartum. And I think that talking about the depression that happens of Aldomet it's not different, from the depression that you get during pregnancy.
Thank you.
I don't know if I've answered your question.
Yeah, Dr. Kayinza, I'm sure she's okay. Here's another, it's an unfortunate situation here from Amanda Kong, that she had preeclampsia 15 years ago. And on the night of a Caesar, another mom in the same boat did not make it. What could have happened?
So yeah, that's really that's what happens. I mean, hypertension, hypertension in pregnancy is a severe condition. Once you have preeclampsia, the morbidity and the mortality is increased. So, but the biggest causes of death in preeclamptic patients is pulmonary edema and stroke.
Yeah, it's quite unfortunate. I'm sure Amanda, on hearing this talk might take us back to that unfortunate situation for the other man.
Yeah.
Dr. Linda Soga wants to know, a very informative presentation. Thanks, Professor. Physicians have been discouraging us from using nifedipine 10 milligrams stead for years for fear of causing a precipitous drop in BP. How is it different in pregnancy? Also, is Aldomet still the drug of choice in managing hypertension in pregnancy?
So we would start. So the South African guideline says that when you're starting a high blood pressure, when you're starting treatment, you will start with Eldermet. And then also what we do is we start with Eldermet. If we don't get control, then we add Adalat. But we add the long-acting Adalat. So then we would go with the 10 milligrams for 3 doses. And just because of this concern of the precipitous reduction. And we would not give Adalat sublingually, also because of this problem with the rapid reduction. But the fluid used to be. So in 2013, we were still preloading with fluid. And now we're not preloading at all. And we're giving three doses. So the American College also uses it, and they use the rapid nifedipine. They start with 10 milligrams, and then they give 20 milligrams, and then they repeat it, and they give another 20 milligrams. So it's really important to bring down this the blood pressure.
Is there a place for, do diuretics affect, in postpartum, affect breastfeeding?
So we're happy to give diuretics in the postpartum period. And so personally, I use a calcium channel blocker. Or I would use, but we do use diuretics. So in patients where we have patients, where we can't get control of the blood pressure, and they are on 3 agents. So 3 agents, if you're on more than 3 agents antenatally, it's also another reason to think that you are looking at delivery within 48 hours. So, but yes, it is fine to use a diuretic.
Okay, maybe one of the last questions. Is there something like a postpartum preeclampsia? And how often should patients be monitored postpartum and also to avoid normotensive patients becoming preeclamptic?
So we do get, I'm trying to think of a percentage. This is a guess that 90% of the eclampsias happen during the antenatal and labor period, and about 10% of them happen postpartum. But we do see them, and we do see patients who are normotensive, and they go home and they come back with hypertension with the seizure. But that's not the biggest number of patients. So the bottom line is that you should not discharge patients with hypertension, or you should not discharge patients who are high risk in the first 24 hours. And if you've got a patient with severe hypertension, you should not discharge them for 3 days. But you're not going to discharge them because they've, even if they don't have organ dysfunction, you struggle to get the blood pressure under control.
Okay. Thank you very much, Prof. We had quite a number of attendees this evening, almost 430, and most of them still here and I'm going to ask Professor Mkunyana to do the closing remarks just before this last question that has just come through. How often should preeclampsia patients be monitored for visual symptoms or even asymptomatic visual eclampsia? I'll get Professor Mkunyana just to do the final remarks.
So if a patient has got preeclampsia and we are looking after them in the ward, then if it's mild or moderate preeclampsia and they're in the lying-in ward, then they have their blood pressure taken every 6 hours, and they get seen once a day by a doctor, and they get seen by the nursing staff, will see them also 4 times in a 24 hours. But once the patient is in high care for whatever reason, they get seen every 2 hours by a doctor. So, and they get seen by a nursing sister every hour. So that would then, they would be asked at every interaction whether they've got neurological signs and symptoms, and whether they've, and they usually in our high care, they're being monitored continuously. So they'll have a SATS monitor, and they'll have their blood pressure, pulse, and respiratory rate recorded every hour. And so because of the monitors, they won't really be waking up, but because they're in high care, that's one of the problems with the high care, is that they don't really sleep very well.
Thank you, Dr. I'm sure the doctor is happy with the response. Professor Makunyane, if you could just say a few words. Thanks a lot, Prof. Adam.
Okay.
Thank you.
Yes, thank you very much. And on behalf of the Risk of a Clinics Health Group, I would like to thank you, Professor Adam, for a very important topic that you've tackled today. Pre-eclampsia, which we know is directly correlated to maternal and infant morbidity. The importance of screening and designing protocols tailored for various populations, and other factors that you have mentioned. I would also like to thank everyone who has joined and actively participated in the webinar. And lastly, I would like to also thank Dr. Bila and his team that is working behind the scenes to make this successful. Thank you very much for having made this webinar once more a resounding success. Thank you, everyone. Over to you, Dr. Bila.
Thanks a lot, Professor Makunyane. We appreciate your presence in our midst this evening, and all members of the risk committee who are here. And thanks a lot, Prof. Adam and the team and everyone. Hope to see you again next week as we continue with our webinar presentations on a different topic. We'll be getting to the emergency room next week. Thank you, and have a good evening.
Thank you, everyone, and have a good evening.
Thank you very much. Bye-bye.
Bye.
Bye.